We'll look at real-world symptoms, hunt for clues, and try to piece together exactly what's going wrong in the human eye. It's like a giant puzzle, so let's get into it. Now, before we crack open our first case, we actually need to ground ourselves in the origins of this academic material.
Dive into this. Our first medical mystery. Imagine you're the clinician and a patient sits down in your examination chair. They tell you they've got vision loss, but here are your clues. It was a constant, sudden onset that happened exactly 1 year ago, and it has stayed completely stable ever since. As a detective, your mind should immediately start racing. Sudden onset that stays stable, that is a huge clue. But it's not enough to close the case. We have a starting point, sure, but the immediate question we really have to ask ourselves is, what other history do we need to extract from this person to figure out what happened a year ago?
Because, well, you can't just ask, how are you feeling? We need to deploy highly targeted essential interrogation questions to rule out immediate dangers. We have to ask about systemic diseases and medications, because things like high blood pressure or diabetes, they can drastically impact the eye. We need to know about their general health, when their last eye exam was, just to establish a baseline. And crucially, we have to ask about pain. Is there pain with the vision loss, or maybe when they move their eyes? That could point to inflammation of the nerve. Oh, and here's a classic red flag. We always ask, is the vision loss like a curtain coming down? If they say yes to the curtain or mention sudden flashes of light or floaters, alarm bells should literally be ringing for retinal detachment. So we're basically triaging the patient right here.
Right. So once we've safely gathered the history, we get to open up our forensic toolkit. Now I know, it looks like an alphabet soup of medical acronyms, but this is exactly how we measure the physical and functional state of the eye. We do a dilated fundus exam to look deep into the back of the retina, an anterior exam for the front. We test VA, which is just visual acuity, how sharp their vision is, and IOP, intraocular pressure, to check for things like glaucoma. We map their peripheral vision with a VF, or visual field test, and use OCT, optical coherence tomography, to get this amazing microscopic cross-section of the eye's layers. Finally, we test how the pupils physically react and use Ishihara plates to check color vision. Every single tool gives us a new piece of the puzzle.
Now, what's really interesting about this slide is how we can actually measure the electrical activity of the eye using ERG, or electroretinography. Basically, when light hits the eye, the retina creates an electrical signal, and we can capture it. But we have a couple of ways to do it. A pattern ERG is highly localized. It just measures macular function. That's the very center of our vision where we see fine, sharp details. On the flip side, a full-field ERG measures the electrical response of the entire retina. And get this, to do a full-field test properly to international standards, measuring both rod and cone photoreceptors, the patient has to sit in pitch darkness for 20 minutes for dark adaptation. It's a super rigorous process, but man, it tells us exactly where the electrical faults are happening. And here is where our first case takes a truly wild turn. When we tested the left eye, we uncovered this highly specific, vivid visual clue. The visual field test, along with the VEP, which measures the brain's visual cortex, showed the exact same defect. A literal Pac-Man-shaped loss of vision. I mean, think about that for a second. We have a mirrored, identical defect showing up in both the physical retina of the eye and the visual processing center at the back of the brain. That is a massive clue. It tells us the problem isn't just, a simple scratch on the lens. There is a profound communication breakdown happening all along the visual pathway. So the really crucial point here is that this mirrored Pac-Man shape loss, paired with reduced peaks in our electrical ERG testing, completely points us away from a surface eye problem and directly toward a deeper neurodegenerative issue. We're looking at a phenomenon called retrograde thinning. What this means is that damage is occurring, and actually it's more like the damage is progressing backward along the nerve pathways toward the eye, which leads to optic atrophy. The nerve fibers connecting the eye to the brain are essentially dying back. It's a complete structural breakdown of the cable connecting the camera to the computer. Putting all these clues together, we can confidently deliver the final verdict for our first patient, optic neuropathy. Let's recap the defining physical signs that got us here. We've got distinct visual field loss, presenting as blind spots or scotomas. The patient experiences a washing out of colors, which totally makes sense if the nerve transmitting that data is compromised, right? And crucially, when we physically look at the optic nerve at the back of the eye, it appears visibly paler, and its margins are blurry, no longer distinct. Now, interestingly, during our exam, we might have spotted some minor retinal abnormalities, maybe odd blood vessels, but because we used a structured investigation, we know those are purely incidental findings. They were total red herrings. The true culprit was the optic neuropathy. Case closed. All right, let's completely shift gears now and see how this builds. We are leaving the adult world behind and stepping into a drastically different medical mystery. Our second patient is a 5-year-old Caucasian female.
Her primary complaint, or PC, is reduced vision in OU, which is just clinical shorthand for both eyes. Now, when you have a patient this young, your entire approach as a clinician has to pivot. A sudden stable loss in a grown adult is one thing, but reduced vision in a developing 5-year-old brain, that is a whole different ballgame that requires a completely different mindset. Because obviously, you can't interrogate a 5-year-old the way you do a 50-year-old. A kid often doesn't even know their vision is reduced because they literally have nothing to compare it to. So we swap out our clinical jargon for practical pediatric interrogation tactics. We ask lifestyle-focused questions. We ask the parents and the child, does this affect her school learning? Is she clumsily bumping into things or hurting herself playing sports? Is she having a tough time learning to read? Can she actually see the blackboard from her desk? We also check for photophobia, meaning, is she unusually sensitive to bright lights? These real-world, everyday questions give us the clinical clues we desperately need without expecting a kindergartner to explain complex medical symptoms. And so, Detective, we arrive at the critical moment of our second case. We've got our practical history, but now I'm turning the investigation over to you. Here is our pediatric toolkit: visual acuity, testing the pupils, checking color vision, doing a cycloplegic refraction to find their true prescription, confrontation visual fields, testing eye motility, and attempting a dilated fundus exam. So, how exactly would you apply these tools to an energetic and probably nervous 5-year-old? Which test is the absolute most critical first step to ensure we don't miss a vital developmental window for her sight? I'm going to leave you with that provocative thought to ponder. Because in the world of clinical eye care, mastering the science is really only half the battle. Applying it to the complex, unpredictable human being sitting right in front of you is where the real art lies. And the sleuthing, it never, ever stops. Thanks so much for joining me for this explainer, and remember, keep questioning everything you see.